Hello and welcome to tonight's Immunisation Coalition webinar event. Our topic tonight or this evening is respiratory syncytial virus update. It's actually preparing for prevention. My name is Andrew Minton. I will be your moderator for this evening. I am the education manager and I work for the Immunisation Coalition. Firstly, I would like to acknowledge the traditional custodians of the various lands on which we work today, and any Aboriginal and Torres Strait Islander peoples participating in this webinar tonight. Welcome. I pay my respects to elders past, present, and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. Presenting tonight's session is Dr. Gemma Saravanis, who will be speaking for around about 40 minutes, which leaves us about 15 minutes for Q&As. I really encourage people to ask the questions and to ask those via the Q&A button at the bottom of your screen. You can use the chat, but I will be focusing mostly on the Q&A box. If we're not able to get to your question or we cannot answer your question in a satisfactory way, we will be looking at those questions and providing answers in the next few days and sending them out to all registered persons on this meeting. Tonight's presentation will be recorded and it will be available in about a week's time on our website. Our website is immunisationcoalition.org.au. Because it's a recorded session, participants will be on mute, and in terms of finish time, we will finish sharp on 7:30 to pay respect to the speaker tonight and all of you participating this evening. We've all got families and it's going to be about dinner time by the time we end, so 7:30 will be the finish time. I just wanted to start, before I introduced our guest speaker, just some facts around where we stand with notifications on RSV this year and last year, just to sort of kick things off. Last year in 2022, there were 96,000 notifications. This year, which peaked a month earlier in July, we're year to date at 98,000. So we might get to around about 110, 115. And the predominant notifications were for the very young and for the elderly population. In terms of comparing this with flu, because it's always nice to compare something and trying to put it into perspective with another respiratory disease. Last year for the flu in 2022, there were 234,000 notifications. And in 2023, there's 209 year to date. So we'll probably get to about 230, 240. So it's about a 2 to 2.5 to 1 ratio comparing RSV to flu. But it'll be interesting to see what those notifications are going to look like over the next couple of years as more patients will be diagnosed and patients will be receiving an RSV vaccination. So now I'd like to introduce our guest speaker tonight, Dr. Gemma Saravanis. She's a researcher, an educator as an associate lecturer and a clinician based at the Susan Wakefield School of Nursing and Midwifery, University of Sydney. She also holds a postdoctoral research fellow appointment at the University of Sydney Children's Hospital and Westmead Clinical School and Centre for Paediatric and Perinatal Infection Research. Gemma has many roles and wears quite a few hats, and her experience in limiting it to just a few areas: public health surveillance, infection prevention and control, epidemiology, and immunisation and nursing. So just before I hand over to Gemma, I'd just like to say that RSV is quite topical at the moment, especially in the last 3 to 4 months. There's been many webinars and activities on this subject. That's primarily because it's the RSV season, but also the excitement around new vaccines becoming available sometime next year. I did have a quick look on the TGA website to see what has been submitted for evaluation. I did work in regulatory some time ago, so it's just kind of very interesting that early this year there was a submission, and there were a couple more submissions in Q2. So given it's a new NCE, given the timeline typically of 12 months to 13 months, plus PI updates, label updates, and so forth, it does look like that hopefully at least we'll have at least one vaccine available next year, and hopefully in time for the RSV season, but we'll have to wait and see. So with that said, I'd like to hand over to Gemma to take us through her presentation on RSV preparing for prevention. Thank you, Gemma.
Thank you very much, Andrew, for that very warm welcome. I'm absolutely delighted to be here this evening, joining the Immunisation Coalition to provide this update on RSV. And I would like to thank very much all of you for joining us as well. I would also like to acknowledge that I'm zooming in tonight from the traditional lands of our First Nations peoples, specifically the beautiful lands of the Darug people at the Westmead Health Precinct in Sydney, which is the site of a major paediatric facility, the Children's Hospital at Westmead, where I've been fortunate to do a lot of my work. I would like to pay my respects to all First Nations peoples and would like to acknowledge their past and continuing connection to country. I've optimistically titled the presentation today, Preparing for Prevention, and I think we can agree there is currently a lot to feel positive about in this space. Okay, now I just want to check that you can see the slides okay on my end, on your end, sorry.
Yes.
Okay, perfect. You can see those main slides, perfect. Okay. Okay, so in this webinar, I'm first going to provide an overview of RSV disease burden and impact. I'm then going to provide an update on existing and approaching preventatives. Andrew's alluded already, there's, and you likely already know, there's quite a lot going on in this space. So I'll really focus on those RSV vaccines that are coming very closely now, and some immunoprophylaxis agents as well. Lastly, I would like to highlight some important activities that we should all be considering as we sort of approach these new preventatives. So thinking about programmatic considerations as well as surveillance, education and advocacy. So we've known about RSV as a serious human respiratory pathogen for many decades now. Interestingly, it was first identified and described way back in 1956 when it was recovered from a coryzal chimpanzee. Very shortly after its discovery here, a link was established between the virus and large seasonal epidemics of childhood respiratory infections, in particular bronchiolitis, that cardinal syndrome of RSV that affects infants aged under 2. It was also established early on that RSV infection doesn't result in sterilising immunity and that reinfections occur throughout life, but those subsequent infections are typically milder. It was named respiratory syncytial virus as it caused the formation of these syncytia in cells or giant multinucleated cells. So when looking in a cell culture in through a microscope, as you can see here in this old micrograph. As you well know, it's a highly transmissible virus that spreads very quickly to close contacts, and outbreaks in settings such as residential aged care facilities, hospitals, and early childcare settings are quite common. Transmission is primarily through droplet transmission, also contact routes. However, there is increasing evidence for an element of aerosol transmission here as well. So since its discovery over 60 years ago, we've learned a great deal about the virus and about the disease it causes. It's very much a disease that affects those at the extremes of age. So in particular, those children aged less than 5 years, where it's the leading cause of severe acute lower respiratory infection. And also older adults, which is understudied but increasingly recognised. So this lovely web diagram here shows that complex interrelatedness of many of the risk factors for severe disease in young children. Young age is really the single most important predictor of severe disease, but other important risk factors include things like prematurity, low birth weight, a lack of breastfeeding, maternal or household smoking, low socioeconomic status, and Indigenous background. In adults, the risk factors are less well characterised. However, we do know that increasing age is a powerful risk factor for experiencing severe disease. Other important factors include the presence of comorbidities. So particularly here, thinking about those chronic comorbidities, chronic cardiopulmonary diseases. So COPD is a big one. Also things like asthma and congestive heart disease. Immunocompromising conditions, diabetes, and neurologic and neuromuscular disease as well. So characterising the full burden of RSV disease across all ages and settings has been a priority for some time now. This information is, of course, essential to inform those decisions around using RSV-specific preventatives when they do become available. Like many diseases, and similar to what we do with influenza, it can be helpful to think about the burden in this pyramid format, with those serious and rarer outcomes such as death at the top and those more common outcomes of disease at the base. So RSV mortality can and does occur. This is predominantly in lower resource settings, but also in at-risk groups, in higher income settings as well. Hospitalisations and ED presentations are predominantly due to respiratory infections. So bronchiolitis, that cardinal syndrome of RSV, RSV is implicated in about 50 to 80% of all cases of bronchiolitis. So a really huge driver of that disease burden affecting our under 2 population. We also see exacerbation of chronic conditions. So I mentioned already chronic obstructive pulmonary disease in adults, and we do more rarely see extrapulmonary presentations. So things like childhood seizures can be important too. The community disease is less well characterised, and it may have a range of presentations. So in addition to those ones already mentioned, we also see those mild upper respiratory tract infections. We see croup, we see otitis media. Community disease is also a really big driver of potentially unwarranted antibiotic use. We're very lucky to have a range of great research in Australia to inform on both the community and the hospital burden of disease in children in our setting. The top results there from an Australian birth cohort study from Queensland found that most children will have their first RSV infection by age 2 to 3, and roughly 1/3 of these children will seek community medical care, and around 2% are hospitalised. So if we look to the national data, this is from the National Health and Morbidity Hospitalisations data from 2006 to 2015, as you can see in the figure there. There were over 7,000 primary RSV-coded hospitalisations in children aged less than 5 years. It's really important to note that this is likely an underestimate of the true number. However, it certainly provides useful information about those trends over time and potential risk groups. Quite clearly here, these data, you can see that rates increased with decreasing age. So looking there at the blue line, you can see infants less than 3 months of age had the highest rates of hospitalisation at around 3,000 per 100,000 of the population. So a really huge number there. Hospitalisations on the whole are short, so we were looking at a median of around 3 days. Aboriginal and Torres Strait Islander children were almost twice as likely to have an RSV-coded hospitalisation compared to non-Indigenous children. Of course, these epidemics present a substantial health as well as economic burden. So there have been some good costing estimates from Australia. So these estimates here suggesting that a hospitalisation cost over $6,000. And when we think about an ICU admission, we're looking at around $20,000. So we can also think about the contribution of RSV to all childhood pneumonia. So this is an excellent case control study that was carried out by the Perch study group. It was set in 7 low and middle income countries and enrolled almost 10,000 young children. And now this study found that RSV was the leading pathogen for pneumonia requiring hospitalisation, and it calculated an etiological fraction. So it was estimated that around 31% of all admissions were attributable to RSV infection. And this was more than 3 times greater than the next leading pathogen. So you can see here in the figure outlining their results, the unstratified column in the unstratified data in column A, and you can see here RSV up the top leading the pack here amongst these range of serious respiratory pathogens. And if you look to column B, which has been stratified by age, so stratifying the under ones and the over ones, and you can really see that it's those children under 1 year of age carrying that driving that greater burden of hospitalisation. So we can also look to global burden of disease studies, and as Andrew mentioned, having that point of comparison can be useful, and there's quite a few different types of data that we can go to look at to draw those comparisons and try and put things into perspective. So these burden of disease studies here are on RSV and influenza in children aged under 5 years old. So we can see that RSV is estimated to cause around 33 million lower respiratory infections in this age group. And this is substantially greater than we see for influenza, which sits at around 10 million is the point estimate. The number of RSV attributable hospitalisations and deaths is also estimated to be greater as well. So we're going to look to the adult population now, and we can see a similar picture. So this is a modelling study from the UK. It considered a range of routinely collected data sets, and it found that in most seasons, RSV contributed to more primary care visits, more hospitalisations, and more deaths in older adults compared to influenza. So if you look to the figure on the right there, you can see those RSV lines in red, and the influenza lines in blue, showing the incidence rate over time. So over here in Australia now, the burden of RSV disease in Australian adults is less characterised, but it is likely to be substantial. So we can look to that RSV coded hospitalisations data again. And if you look at that figure there, you can see between 2006 and 2015, that really steep increase in RSV coded hospitalisations in the over 65s. So that's that purple line. This is most likely due to increased diagnosis and testing. These data also suggest higher rates of hospitalisation in Indigenous adults, actually at a younger age, so sort of looking at that 35 to 55-year-old age group. We see a significantly greater length of stay compared to young children. So the median length of stay in adults over 65 is 6 days. And we also see a substantial number of in-hospital deaths in this group. So a recently published Australian modelling study suggested that the true number of hospitalisations in older adults is in fact much higher than would ever be estimated through this coding data. So they actually estimated that it was around 8 times higher in adults 75 years and older. So we can also now look to our RSV notifications, and you can see if we just look at this group in particular, our over 65s, we've already got, we have about 16,500 of older adults testing positive for RSV so far this year. Notably, we really do need more studies characterising that incidence and the risk factors associated with severe disease in our adult population here in Australia. And this is going to be critical in informing the best use of this RSV-specific prevention. It is also really important to note that the burden of severe RSV disease is not distributed equally when we look globally. So while in high-income countries, we absolutely do observe a very large burden of disease, that disease burden is even greater in other parts of the world. With those areas with the lower socio-demographic index, you can see here at the SDI, the acronym there, risk factors such as malnutrition and poor access to healthcare are potentially big drivers behind that. So when we consider deaths and disability-adjusted life years, and we look between 1990 and 2019, there have been really, a lot of progress with declines over these past 30 years. However, these are absolutely not uniform globally. So we still see that greater burden of disease carried by these lower socio-demographic areas. The figure here on the right shows RSV-associated deaths, and we can see that those lower socio-demographic areas carrying that largest burden of RSV deaths. Interesting to note that older adults in these areas have actually taken over from young children, looking from 1990 to 2019. So there are a range of other important impacts associated with RSV, which I'm just going to touch on lightly. So I think a really important thing to note, and we're hearing more about this, is that mounting evidence that early RSV infection can cause later onset asthma. So I'll draw your attention to this recent birth cohort study, which followed children over time. It studied healthy infants, and it found that RSV infection in early life contributed to around 15% of asthma at age 5. So this, of course, was adjusted for those other known risk factors, such as the sex of the child, ethnicity, breastfeeding, daycare attendance, exposure to smoke, and maternal asthma. There's also evidence that, like influenza, RSV can trigger cardiovascular events, so myocardial infarctions and heart failure in adults. Quality of life impacts is another important consideration, and we're increasingly studying this, and this will be important to incorporate into cost effectiveness calculations. So here, these studies are considering things such as RSV symptoms, disruption to activities, to work, to school, and so on, and just that level of parental stress and concern. Of course, healthcare resource consumption, as we know too well across all settings, needs to be acknowledged. RSV really makes a big contribution to the winter surge that we see, and that pressure on our health facilities and our health professionals. There is also to be acknowledged the overuse of non-recommended low-value interventions in bronchiolitis, and also overuse of antibiotics. Lastly, I just want to mention healthcare-associated infection is important, and a number of studies have now highlighted this as a strong predictor of in-hospital mortality. So when I talk about RSV, I do like to put a face to these large population numbers and rates. For many of you working in primary care, paediatrics, or ED, you've probably seen many children like this in your careers. This is the story of Oscar. He was just 2 months old, and he came to the Sydney Children's Hospital last year with severe RSV bronchiolitis. He presented to his local hospital, but when he continued to deteriorate, he was transferred by the Newborn and Paediatric Emergency Transport Service, affectionately known as NETS, to the Sydney Children's Hospital here in Randwick. Oscar was found to have a partially collapsed lung due to severe coughing episodes, and he required 6 days in the ICU with ventilation support and a course of antibiotics. Thankfully, he made a full recovery, but you can begin to imagine the stress experienced by little Oscar and his family. His mother reflected on how helpless she felt seeing Oscar hooked up to the breathing support, but she also spoke of that reassurance she received from the healthcare professionals who cared for them. So now I'm going to share some positive news with you. And we really are on the cusp now of potentially multiple new vaccines and therapeutics that can prevent RSV infection and begin to mitigate this large burden of disease, both in Australia and globally. I'll first touch on existing prevention before I provide an update of a few vaccines and next generation monoclonal antibodies. So first, as I said, I'm going to touch briefly on our existing RSV prevention armoury, which is limited at best. Of course, we have our good basic infection prevention and control measures. It's really that core prevention, as we know from COVID. It's about isolating individuals who are symptomatic, promoting and supporting that good hygiene, so our hand hygiene, respiratory hygiene, environmental hygiene as well, so cleaning. Face masks can be appropriate in some settings, so particularly in healthcare settings and when people need to go out when they're symptomatic, face masks are absolutely encouraged. So we do have one existing RSV preventative. This is known as palivizumab. It's a monoclonal antibody which provides passive immunisation. It's only recommended for high-risk infants. And I'm going to touch on that in a little bit more detail in the next slide. Some other important factors to think about. Certainly we know that a lack of breastfeeding is a risk factor for severe disease. So it's reasonable to think about promoting and supporting breastfeeding as providing protection against RSV. Similarly, thinking about maternal and household smoking as a risk factor and supporting smoking cessation is also really important. Lastly, I just want to make note of this interesting recently published study led by my colleagues at the Telethon Kids in Western Australia. They found that influenza vaccine in children may provide a small but significant non-specific protective effect against RSV disease. So yet another compelling reason to recommend flu vaccine to our patients. So looking here at the one existing RSV preventative that we do have, so you might know it by either of these names, palivizumab or Synagis, the trade name there. This is a short-acting monoclonal RSV antibody which targets the F protein. So it's considered passive immunisation. So it works, I guess, in a similar way as you might think about maternal immunisation. So bub gets antibodies. So it is short-lived. It's recommended for high-risk infants. So broadly, these are infants who might be extremely preterm. They might have chronic lung disease or congestive heart disease. The recommendation is for monthly intramuscular weight-based dosing, so up to 5 doses during the RSV season. It's generally efficacious. It can reduce RSV hospitalisation by around 56% in these children. But there are a lot of barriers to its use. It's very costly and the guidelines are very variable. And the majority of this therapeutic is delivered in the hospital setting. So you can begin to imagine some of the barriers in terms of service delivery and access for people to uptake this therapeutic. So before I provide an overview and an update of some exciting approaching RSV preventatives, I would first like to acknowledge the long and somewhat checkered past of RSV vaccine research and development. This is an important contributor to the foundation of the efficacious and safe vaccines that we currently have in the pipeline. Additionally, patients in the community might have questions about this history, and it's important for us as health professionals to be able to understand and respond to these. The first RSV vaccine candidates were a formalin inactivated protein subunit vaccine targeting the F protein of the virus. These early clinical trials resulted in unexpected and tragic outcomes. So vaccine-associated enhanced disease occurred in vaccinated RSV-naive children following natural infection. Very sadly, this resulted in a number of hospitalisations and 2 deaths. It is really important to note that currently FVF protein subunit vaccines, so those protein-based vaccines, are reserved for the adult population due to concerns around this vaccine active enhanced disease. And if you do want to read a little bit further about that, I've provided 2 good references for you can go away and take a look at. So currently there's a rich and complex RSV preventative landscape with over 30 candidates in clinical or preclinical development. And the development pathway has been guided by over 60 years of learning about RSV, failed clinical trials over time, and more recently, significant advances in vaccine and monoclonal antibody technology. So when we look at the products in development for these different target groups, here looking at pediatric, maternal, and the elderly population, we can see a number of different product types. So the live attenuated and the trimeric or hybrid virus vaccines are favoured in children because they're considered safe for RSV naive infants. And they've also demonstrated an inability to prime for that vaccine-enhanced disease I mentioned. Vaccines based on viral vectors and nucleic acids, so those RNA vaccines, for example, are also thought to be a safe option for children who might not have had their first RSV infection. In adults, we see these more traditional protein-based vaccines. They typically target the F protein. So you can see in the image of the virus particle there, the F or the fusion protein is that protein there in the green. These are favoured in elderly or maternal immunisation delivery. And this is again owing to those concerns. These vaccines might cause vaccine-enhanced disease in naive infants. So just looking a little bit more closely at that F fusion protein, this is really the most common vaccine and monoclonal antibody target for candidates in development. And many of you might have heard this term post-fusion and pre-fusion conformation. And I'm going to just break that down for you a little bit more. So we zoom in on that green F fusion protein. Is a graphic or a schema of what it looks like. And you can see we've got these two conformations. So that first one on the left there is the favoured target. It's the pre-fusion F trimer. So that is the conformation it takes before it binds to those epithelial cells in the airway. And that's shown to be a preferred target, producing a better and stronger immune response. Historically, some of the candidates which have failed have targeted this post-fusion trimer, which has actually changed shape considerably, as you can see in the graphic there. So this is the RSV vaccine and monoclonal antibody snapshot, which is published by PATH in the US. I've found this to be a great reference point, and I've absolutely loved following this and watching it evolve over the past 5 years or so. You can see to the right there, the 4 market-approved products in the US, now in the far right column. So we've already spoken about palivizumab, which is the one existing monoclonal antibody that we have. It's been around for a little while now, with variable uptake in Australia and globally. I'm going to focus the rest of this webinar on talking a little bit more detail about the other 3 recently approved products. So these products are, firstly, at the top there, we've got Advocacy, which is produced by GSK. It's a protein-based vaccine. It targets the pre-fusion F protein, and it's also an adjuvanted vaccine. The target group for this vaccine is older adults, 60 years and older. It currently has approval by the FDA in the US and the EMA in Europe. Here in Australia, it is under evaluation with the TGA. The next candidate there is Abrevzo. It's produced by Pfizer. Similarly to Advocacy, it's a Prefusion F protein vaccine, so another protein-based vaccine. This vaccine is targeting older adults here again, so adults aged 60 years and over. It's similarly has approvals now in the US and in Europe and under evaluation by the TGA. So you'll notice a little asterisk there. So interestingly, in Europe, this vaccine has also been approved for use in pregnant women as a maternal vaccine to protect infants in those early months of their life. And the last product there is actually not a vaccine, but it's a very exciting next generation monoclonal antibody. You might have heard of it as Notifiable, or perhaps by Fortis, the trade name. It's produced by Sanofi Aventis, and it's a long-acting monoclonal antibody. So it's delivered with a single dose and provides protection for the duration of the RSV season, and it's considered passive immunisation. This particular product is to protect our young infants, so those under 24 months of age. This has gained approval in the US, in Europe, and also in the UK, and it has achieved, it is under evaluation here in Australia with our TGA. Okay, so first going into a little bit more detail on Advocacy. So this is our protein vaccine, which is adjuvanted for older adults. These data from a phase 3 clinical trial here. So 17 countries, almost 25,000 immunocompromised participants aged 60 years and over. Vaccine efficacy was very good at 82% for RSV-associated lower respiratory tract disease in the first season. And these participants were followed over 2 RSV seasons. So that efficacy did reduce in that second season. So overall for 2 seasons, sitting at around 75%, which is still a very good result. In terms of vaccine safety, serious adverse events were similar in the intervention and the control group, which is good news. There was certainly a higher reactogenicity, so solicited local and systemic reactions, so muscle pain and local injection site reactions, so 3.8 compared to 0.9%. So here I'm going to the next candidate. So a similar product, Breastfed, manufactured by Pfizer. So it's another classic protein vaccine targeting the Prefusion F protein. It's targeting older adults. And here looking at this phase 3 randomized control results here from 7 countries, around 37,000 immunocompetent participants, similar and really positive looking vaccine efficacies here. So 90% in the first season and dropping to an overall 84% across the 2 seasons. So serious adverse events here, again, similar to the intervention and control group. So no significant safety concerns were noted. There was a slightly higher reactogenicity, less with the adjuvanted vaccine. So here looking at about 1% to 0.7%. So here now, just looking in Europe, where Breastfed has gained approval from the EMA to be used in pregnancy. So as I said, to provide passive immunisation to their babies in those first few months of life. We can see this clinical trial here, so 18 countries, over 7,000 pregnant women enrolled. Again, here really excellent vaccine efficacy, so 82% efficacy here against medically attended severe RSV-associated lower respiratory tract infection within 90 days of birth. So really providing that, that protection in those first 3 months of life where we know the rates of severe disease are highest. So they also looked a bit further, so 69% efficacy in preventing for that primary outcome within 180 days of birth, so up to 6 months. So really, really positive results there. So the serious adverse events were similar in the intervention and control group. Reactogenicity, injection site pain, muscle pain, headache was more common in the intervention group, as we would expect. So we don't yet have advice from our regulatory bodies here in Australia about these products, as they haven't been approved, but we can look to recommendations from the US and UK. So interestingly, some quite different recommendations here. So the Advisory Committee on Immunisation Practices, that's ACIP, in the US, recommend that adults aged 60 years and over may receive a single dose of RSV vaccine using shared clinical decision-making. So this is a sort of a nice point, clinical decision-making with the patient, but it does perhaps provide some practical issues about recommendations and maybe not a great deal of clarity there. So they also did note across the clinical trials for these particular products for older adults, 6 cases of inflammatory neurological events occurred. So thinking about things like Guillain-Barré syndrome there. So these were reported after RSV vaccination. The proportion was extremely low, and post-marketing surveillance will be important to determine if this is just due to chance or if there is a causal relationship. Going to the UK, so we've got the Joint Committee on Vaccination and Immunisation, and they advise a little bit more specifically a program for adults aged 75 years and older as a one-off campaign, and then a routine program for those when they turn 75 years of age. They also highlight that there's currently no product preference, as they perceived that the products had comparable efficacy. Okay, so now we're now at our monoclonal antibody, so Fortis or nirsevimab. So let's spend a little bit more time looking at this, because it's not a typical vaccine. It is a monoclonal antibody. It's quite similar to the product that we already have, so palivizumab. But as I noted, it's a long-acting, single-dose monoclonal antibody to provide passive immunisation to young children. And it's now approved in the US, the UK, and Europe. So these data from the phase 3 Harmony trial. So this particular study here looking at France, UK, and Germany, over 8,000 infants. It's that single dose pre the RSV season. So vaccine efficacy here, so 83% for RSV hospitalisation, and interestingly 58% for all-cause lower respiratory tract infection hospitalisation. The serious events were slightly higher in the intervention group compared to the placebo, but this was considered not significant. And we see those expected and common adverse events, so injection site reaction and rash being more common in the intervention group. So the Advisory Committee on Immunisation Practices in the US determined that nirsevimab is eligible for inclusion in their childhood immunisation schedule and vaccines for children program. They provide a recommendation for all infants aged under 8 months born during or entering their first RSV season, and also children aged 8 to 19 months who are at increased risk of severe RSV disease and entering their second season. An interesting study over in the US considered the optimal site for actually for service delivery and administration of this product, and it found that providing nirsevimab in the newborn nursery may be preferable to minimise access disparities that they saw between different population groups, particularly looking at people who weren't privately insured. So a little bit different here in Australia, but still certainly something that we can be thinking about. Over in the UK, JCVI has reported a preference for a year-round program, which it believes will improve uptake and reduce operational complexity, which would be associated with a seasonal program. So again, here we're seeing quite different recommendations between our US and UK neighbours. So here's just a little bit more product information on this particular product, because it is perhaps a little bit different from what as immunisation providers we're used to. It is delivered in much the same way. It's an intramuscular injection. It's a single dose. The dose varies by age and weight. It can be administered simultaneously with other vaccines. So clinical trials certainly demonstrated that there were no safety or reactogenicity flags during those trials. Similarly, it must be stored according to cold chain, a little bit more temperature stable than some of our other vaccines. So here, product information stating it can be at room temperature for up to 8 hours. Okay, so I'm going to round up the webinar by highlighting some of the areas that I think are important to be thinking about as we approach recommendations from our own regulatory bodies here in Australia, and thinking about actions that we can all take as healthcare professionals. So firstly, we must acknowledge that robust RSV surveillance is critical to support near real-time monitoring of disease and impact, but it's also going to be critical for supporting the evaluation of the impact of these new RSV preventatives after they've been implemented. So as Andrew already alluded to, RSV was made a nationally notifiable disease recently in 2021, which is really great news. And for just this year alone, I've got a similar number to Andrew there. So at the 19th of August, around 97,000 notifications nationally, about 38% coming from New South Wales. So just reflecting population sizes there really. So this figure here, straight from our notifications data, shows the 2023 notifications by age group and sex. And you can see that predominance of notifications coming from the under 5-year-old age group, as we would expect to see. There are also bigger numbers from older children and older adults. So if you look a little bit more closely at that figure, and it will be very interesting to see how this evolves over time. So I have to acknowledge my bias here coming from New South Wales, but I think New South Wales has really been leading the way in terms of respiratory infection surveillance, really pre-COVID and also during COVID. So these weekly respiratory surveillance reports are published in open access. They provide near real-time update of the impact of a range of respiratory pathogens in different population groups. This figure from New South Wales Health's latest report shows the rate of RSV notifications per 100,000 of the population by age. And again, here we can see in that red line, the brown line there particularly, it's those young children dominating here with the highest rates. So the next one here is a figure showing the percent positive of all the RSV tests submitted to Sentinel laboratories, and showing here we are at present this sharp drop as we likely approach what we hope is the end of the RSV season. So these surveillance data are, of course, reliant on comprehensive laboratory testing. However, respiratory pathogen testing for RSV and many viruses has been somewhat controversial, largely due to a lack of evidence for clinical benefit in the absence of pathogen-specific management. There is an increasingly compelling argument for respiratory pathogen testing, at least for those big three. So thinking about influenza, SARS-CoV-2 and RSV. Respiratory virus infections frequently have overlapping symptomology. So you can see here RSV in the green, really overlapping very much, with flu and rhinovirus and seasonal coronavirus, the runny nose and the cough as those dominating symptoms. And testing is really needed to discriminate between these pathogens. So it does confer a range of individual and population benefits that can include supporting accurate surveillance and disease burden estimates, vaccine effectiveness studies, as we do really nicely for influenza with FluCam. There is a role for clinical management, perhaps thinking about antivirals for influenza and COVID being really important ones there. And there may be other benefits So these are things like reducing antibiotic use, guiding isolation and exclusion, and possibly supporting counselling of our patients as well. There is absolutely a need for evidence-based clinical guidelines, however, to guide the use of testing in our clinical settings. So I think we can all agree that education and advocacy is core to our role as health professionals, and we need to think about identifying, addressing gaps for both our health professional colleagues as well as patients, parents, carers and consumers. And so we are seeing a lot more happening in this space, and I nod here to my colleagues Jane Tuckerman and Margie Danchin, who published this lovely piece recently in the conversation, so I urge you to go away and have a look at that. Certainly there's a lot more we can do in this space for adults too, I think. Okay, so this is my final slide now, and I'm almost to time. So really, this is just a summary of actions that we can take away as health professionals, acknowledging that many of these things are already core to your daily practice. So absolutely, we need to keep promoting and supporting that basic infection prevention for all of our respiratory infections. So typically thinking about those hygiene measures, encouraging isolation of symptomatic people, also thinking about those other factors, so those underlying factors such as promoting breastfeeding, smoking cessation, and routine vaccination to provide protection for our patients. I also encourage you to think about your role in RSV testing and surveillance, thinking about those individual and population benefits that we spoke about. Of course, we really do need practical clinical testing guidelines, and these should be collaboratively developed with clinical, laboratory and public health partners. Education and advocacy is core to what we do as health professionals, so please think about potential gaps for members in your community, both other healthcare professionals as well as patients. And finally, we know that recommendation from a healthcare provider is a powerful predictor of vaccine uptake. So when RSV preventatives are approved and recommended by our regulatory agencies here in Australia, we absolutely need to make sure that the relevant health professionals are equipped to recommend and provide them. So in closing, I would like to acknowledge my collaborators and colleagues for their support and input into these materials. In particular, I'd like to acknowledge Sydney ID and also Philip Britton, who leads the Centre for Perinatal and Paediatric Infections Research at the Children's Hospital at Westmead. And finally, I thank you for your attention this evening and for joining us for an update of RSV.
Thank you, Gemma, for providing a really detailed overview of RSV, including disease burden, epidemiology, and available RSV vaccines overseas, which will likely come to Australia. We do have, I don't need to use some of my questions because we have a number of them already, so I'll just read them out. So from John here, can we distinguish RSV clinically in young children or older adults? My impression is that wheeze tends to discriminate. Otherwise, we need to do a PCR test. Your thoughts?
So look, absolutely a really good question. I think a lot of people have made a lot of efforts to try and, align our clinical syndromic presentations with, with our respiratory viruses, which can be very, very useful. And so, of course, those classic presentations of bronchiolitis and wheeze often being associated with RSV, particularly in, periods of high circulation. But really, we still do need a level of testing to discriminate that. The question is, where's the sort of cost benefit in testing particular patients, and I think that's something that we need to determine what the benefit is.
Okay, thanks. We have 5 minutes actually. So this is from John, also a different John. How long will immunity last? So is it going to be a similar? You showed some data for up to 24 months, and is it going to be like another flu model where the virus changes annually and we need to change the composition to reflect the new strain, or how's that going to look?
Yeah, so all great questions there again. So I think I'll work backwards there. So we do know sort of genomically that RSV is a much more stable virus compared to influenza. And so we shouldn't expect to require annual updates. However, the duration of immunity is still, something that we're learning about. So those vaccine trials looking at those protein-based vaccines for older adults, they've looked across 2 years and have found good evidence of efficacy, albeit decreasing efficacy, over time, as we would expect. Similarly with our monoclonal antibody, we're looking, we have good data sort of up to 6 months, which I think is quite good there again. Now, was there another component of that question that I missed? What will it look like? Look, interesting to note, I think in the UK, they're not encouraging a seasonal, but they've recommended a once-off campaign, so at 75 years of age.
Okay. This is from Mona. What is the age group of children recommended for pavlizumab? So schedule. She's got in brackets 5 doses.
Yes, so palivizumab, so the guidelines are quite variable. The uptake is overall is not great. The age group typically under 1 in the first season for high-risk infants, and then in certain cases also in that second year of life.
This is an anonymous question. You mentioned in mRNA vaccine for RSV. Any update on that?
Yes, and so that was a notable admission in my presentation. So a little bit less information out there about that, but I think we can all agree the mRNA vaccine space is really exciting. So there is absolutely a candidate which is currently received fast track priority status with the TGA. It's a Moderna vaccine. So Moderna have obviously been a great driver of mRNA vaccine technology. This is firstly going to be assessed in older adults. There is future potential also as a maternal vaccine and in the pediatric space as well. So yeah, look, mRNA technology. So Moderna have a few products in the pipeline. So these are definitely something to watch as well.
Okay, thanks, Gemma. Should we routinely test for URTI cases?
So look, I think that's another big question. I think we really need to call for practical guidelines, and I think there again it really needs to be something that's developed in partnership with laboratory, clinical, and public health people.
Are there any risk groups not currently vaccine coming? That was one of the questions I had, which also Richie touches on that. Is it suitable for immunocompromised people?
So was that risk groups not covered, Andrew, and
Yes.
Immunocompromised people? Yeah, so absolutely. Look, I think we've really got a bit of a gap in the age brackets there that you might have picked up in. So we've got these monoclonals targeting the very young. We've got these vaccines for older people and potentially pregnant women. But currently there's nothing to provide protection or recommended in that those middle ages of life. And so particularly thinking about older children and also adults who might have chronic comorbidities, who might be at a higher risk of RSV disease. So I think that's definitely a space to watch. And certainly there are some other products a little bit further away in the pipeline in clinical trials.
An anonymous question here, and last question, I'm afraid. So with the influenza vaccination, which starts prior to the flu season, do you think that it makes sense, and it will be that the RSV vaccination will occur at the same time, and as a co-administration?
So Andrew, good question. I know we touched on this briefly before. So there is a little bit of data around about this. So with Advocacy in their clinical trial, so that's the protein vaccine for older adults. They did co-administer that with flu vaccine and didn't raise any safety concerns. So that's promising. and it will be something that will be monitored post-marketing as well, of course. And with Fortis, the monoclonal for the very young, that similarly, that was co-administered with childhood vaccines, and no safety concerns there either.
Okay, thank you. I'm going to have to wrap it up. It is dead on 7:30. So thank you, Gemma. And there is one last slide, if I could just bring that up, just to finish off on that. So yeah, again, thanks for everyone for participating. It was quite engaging. So as I said, any questions that were not answered, we will answer those and send them out to everyone on the talk tonight. I just want to give a bit of a plug for up and coming events. I'll start with the pertussis webinar on the 13th of September. That's presented by Dr. Andrew Beard, who's a GP. All this information is on our website. And on the 7th of October, we have our first primary care infectious disease meeting. It's a one-day hybrid meeting. It's a little bit different to the normal meeting where it has short and long presentations. It has workshops and panel discussions. And for the GPs, it is CPD accredited, whether or not you attend the event in Melbourne or whether or not you attend online. The evaluation form will be sent to you if it already hasn't been sent to you. If you could fill it out, it's just a couple of minutes. We're always looking to improve our webinars and also consider other topics. So thanks again for your participation. I'll say good night and we'll see you hopefully on the 13th of September. Thank you.